So I want you to imagine just for a second that you are the Minister of Health for a nation of, say, 50 million people.
Okay. Quite the promotion.
Right. And you have access to the most staggering medical advancements in human history.
We're talking mRNA vaccines, precision oncology, all of it.
Exactly. You've got highly trained surgeons, dedicated nurses working around the clock. You essentially have the most advanced, powerful engine ever built sitting inside this massive, state-of-the-art ocean liner.
Sounds like a pretty solid setup.
It does. The ship is powerful, the crew is ready, but as you walk up to the bridge to take command, you realize there is a catastrophic problem.
Oh, no.
Yeah. The steering wheel is completely disconnected from the rudder.
Wow.
The navigational compass is just spinning wildly, and the officers on the bridge aren't talking to each other at all. I mean, they're all shouting completely different coordinates into different radios.
That is a terrifying scenario.
It really is, because it suddenly hits you. You know, it does not matter how powerful the engine is. It doesn't matter how brilliant the crew is.
Right. Without a functioning steering mechanism.
Exactly. Without a clear direction and a coordinated bridge, that ship is either going to drift aimlessly into the open ocean or it's going to accelerate straight into a reef.
And that is exactly the crisis we are facing in public health today.
Mm.
I mean, that imagery perfectly captures the root of the word we are exploring today.
Which is governance, right?
Yeah. The term governance actually comes from a 14th century Latin word, gubernantia.
Gubernantia. I like that.
And it literally translates to, quite simply, to steer.
To steer. Well, welcome to the deep dive. Today, we are cracking open the hidden mechanics of global public health.
We really are.
This is your companion guide to Chapter 6.8 of the Oxford Textbook of Global Public Health. We're looking at the governance and management of public health programs.
But, you know, we aren't just going to read you a syllabus here.
Definitely not. We are here to conceptually unpack these frameworks, to strengthen your system's reasoning, and to really support your active reading of the text.
Because if you are a medical student or a junior doctor or, say, a public health trainee, you absolutely need to understand the steering wheel.
You really do. So, to set the stage for why this is so critical, let's look at a central paradox.
Right. The one the World Health Organization highlighted back in their landmark 2007 report.
Yeah, they pointed out something that honestly should make all of us stop and think.
They pointed out that the world has never, in the entirety of human history, possessed such a sophisticated arsenal of interventions.
Right. Technologies for curing disease and prolonging life. We have the engine.
We do. Yet, despite this unprecedented medical firepower, the gaps in health outcomes between different populations are actually widening.
And I want to push back on that, or at least play devil's advocate for a second, because it feels entirely counterintuitive, doesn't it?
It does seem backward.
I mean, if we have better medicine, shouldn't everyone, by default, be getting healthier?
You would think so.
Right. Like, if we know exactly how to treat tuberculosis, why on earth is the gap widening?
Well, you would logically think that the medicine itself solves the problem. But the WHO concluded that the power of existing medical interventions is simply not matched by the power of health systems to actually deliver them.
Oh, I see.
Yeah, the failure isn't in the molecule. The failure is in the delivery, the coordination, the tracking, the financing.
It's a failure of steering.
Exactly. It is a failure of governance.
And this is exactly why you listening to this right now need to pair. Because you can memorize every single clinical pathway.
Every single one.
You can know the absolute gold standard evidence-based intervention for, say, managing diabetes. But if you do not understand the institutions, the incentives, and the governance structures steering your hospital, your implementation is going to hit a brick wall.
It really will. We are making a massive shift in our thinking today.
We are moving from focusing purely on interventions to understanding institutions.
Because public health does not operate in a sterile vacuum. It functions within incredibly complex, often really messy structures.
So true.
And these structures determine what gets prioritized, who gets funded, who is held accountable, and how performance is even measured.
Basically, if you don't understand the rules of the road, you cannot drive the car.
Exactly.
Okay, let's unpack this. Let's start with the absolute foundation, because I think people use the words government and governance interchangeably all the time.
Oh, constantly.
I know, I have. But the textbook makes a very strict conceptual distinction right out of the gate. So, practically speaking, what is the actual difference between government and governance?
It is a vital distinction. Historically, yes, people equated the two. The state was the ultimate authority.
Right, the king or the parliament.
Exactly. But in modern usage, Government, meaning the state itself, the parliament, the civil service, is understood as just one highly formalized form of governance.
Just one piece of the puzzle.
Exactly. Governance is a much broader umbrella. Governance transcends the state entirely. Well, today, you cannot understand how a society steers itself without recognizing that modern governance relies heavily on the consent of the governed. And it incorporates two other massive pillars alongside the state:
Which are?
the private sector and civil society.
Okay, so government is just one player on the field now. It's like the official rule book.
That's a good way to look at it.
It's printed, it's formal, it has specific penalties if you step out of bounds. But governance is the actual game being played on a Sunday afternoon.
Yes.
It's how the players, the referees, the coaches, the fans, and even the corporate sponsors all interact in real time.
Right. It's the unwritten rules, the momentum shifts, the collective action of everyone in the stadium.
That analogy really helps clarify it.
It captures the dynamic nature of the system perfectly. The rulebook is static, but the game is fluid.
And how did the official agencies define it?
Well, the United Nations Development Program, the UNDP, defines governance as the exercise of political, economic, and administrative authority to manage a country's affairs.
That sounds very broad.
It is. It includes all the complex mechanisms through which citizens articulate their interests, mediate their differences, and exercise their legal rights.
But there's an even broader definition from a scholar named Dodson, right? The textbook highlights it as particularly relevant to public health.
Yes, Dodson defines health governance simply as the collective action of a society pursuing common goals.
The collective action of a society. That directly echoes Etchison's classic definition of public health, doesn't it?
It really does.
The one that says public health is the science and art of preventing disease through the organized efforts of society.
Notice he didn't say through the organized efforts of the Ministry of Health.
Exactly. The organized efforts of society. That means the local community outreach group, the multinational pharmaceutical corporation, the academic research institution.
The labor union.
Yeah, they are all active participants in public health governance. It is a total paradigm shift away from state-centric thinking.
It really is.
But, I mean, if everyone is involved, it sounds like absolute chaos. How do we make sense of a system where a local charity and the federal government are both somehow governing health?
Well, to manage that complexity, we have to view public health governance as a complex adaptive system.
Okay, break that down for me.
The WHO developed a very helpful framework for strengthening health systems. They broke them down into 6 core building blocks.
Let me list those out so you, the listener, have the mental architecture in place. The 6 building blocks of a health system are 1, service delivery.
Right.
2, the health workforce. 3, information systems. 4, medical products and technologies.
Do you have them there?
5, financing. And 6, leadership and governance.
Now, if we connect this to the bigger picture,
Yeah.
what is crucial to understand is that the 6th block, leadership and governance, which the WHO often refers to as stewardship, is not just another block sitting neatly next to the others.
It's not just a standalone pillar.
No, it is the pivotal block. It is the central nervous system. Stewardship coordinates all the other 5 blocks.
Ah, I see.
It is the function that ensures the financing actually reaches the workforce, that the information systems accurately inform service delivery, and that medical products are safely regulated.
It's the steering wheel again.
Exactly.
But the chapter takes this a step further. It applies general systems theory to these blocks. And this is where we have to translate some dense academic language into ground-level reality.
Always a good idea.
The text describes health governance as an open system. What does that actually mean for a clinician on a Tuesday morning shift?
An open system in systems theory simply means that the organization is constantly interacting with its external environment. It is not closed off.
Give me an example.
Well, a hospital takes in inputs, right? Funding from the government, new medical graduates from universities, sick patients from the community.
Right.
It transforms those inputs through care, and it exports outputs, healthier patients, data, medical waste. But because it is an open system, it is also subject to entropy.
Entropy, like in physics, the gradual decline into disorder.
Precisely. If a health system stops taking in new energy, like if funding dries up, if staff burn out and leave, if it stops adapting to new epidemiological data, it will succumb to entropy and fail.
But because it is open, it can arrest that entropy, right?
Yes, by bringing in new resources, changing its policies, and adapting to the environment.
There is another term here that always trips people up. The text mentions a characteristic of open systems called equifinality.
Yes, equifinality.
That is a massive $10 academic word. I want to break this down because it fundamentally changes how we judge health policies. What does equifinality actually look like in the real world?
It is a deeply empowering concept once you decode it. Equifinality basically means that in a complex open system, you can achieve the exact same final goal through entirely different initial inputs, pathways, and processes.
So there is no single right way to solve a complex problem.
Exactly.
Give me a concrete example. Show me equifinality in action.
Let's look at maternal survival rates, which is a classic indicator of overall health system strength.
Okay.
You could have two different countries, country A and country B, that both achieve excellent world-class maternal survival outcomes.
Right.
But country A might achieve this through a highly centralized, publicly funded national health service. The government owns the hospitals, employs the midwives directly, and funds everything through general taxation.
Okay, the classic beverage model, like the NHS in the UK.
Exactly. Now look at country B. They achieve the exact same maternal survival rate, but through a completely decentralized, private insurance-based system.
Really?
Yeah, they heavily subsidize care in private hospitals. They rely on a robust network of community nonprofits for prenatal education, and it's funded through mandated employer insurance.
So they start from completely different political ideologies, they use different financing mechanisms, they have different organizational structures,
Right.
but they arrive at the exact same final destination. Mothers are surviving childbirth at world-class rates. That is equifinality.
Precisely. And the lesson here is profound. There is no single perfect blueprint for a health system that you can just copy and paste from one country to another.
Because the context matters so much.
Governance has to adapt to the specific environment, the culture, the history, and the economic reality of the society it serves. What works in Sweden might fail catastrophically in Brazil, not because the intervention is wrong, but because the institutional ecosystem is different.
Which perfectly brings us to the actual players in this ecosystem. We established earlier that modern governance involves three massive subsystems.
The government, the private sector, and civil society.
Right. Let's really pull these apart, starting with the biggest force in the room, government and its instruments.
When we analyze the government's role in health governance, we first have to look at how its power is structured geographically.
Okay.
The text draws a sharp contrast between unitary governments and federal systems.
Right. So in a unitary government, think of the UK, Singapore, or New Zealand power is concentrated at the national level.
Yes, the central parliament makes the policy, and it dictates how that policy is administered down to the local levels.
It's a very clean top-down flow of authority.
It is. But in a federal system like Canada, Australia, the United States, or Germany, power is constitutionally shared and divided between the national government and the provinces or states.
And this creates massive, complex jurisdictional ambiguity.
It does.
If I can imagine. If there is a sudden outbreak of a novel virus, who is actually legally in charge?
That is exactly the friction point. The text highlights Canada as a fascinating case study here.
What happened in Canada?
Well, the Canadian Constitution, drafted over a century ago, gave the majority of healthcare responsibilities to the provinces under the broad umbrella of property and civil rights.
Okay.
But the Constitution obviously didn't explicitly spell out who was responsible for public health in the modern globalized sense.
So you have the federal government trying to manage a national cross-border health threat.
Right.
But the individual provinces hold all the legal cards for actually delivering healthcare on the ground.
Right. And during a public health emergency, this ambiguity can turn into an administrative nightmare.
I bet.
Each province has the constitutional authority to enact different containment policies, varying standards of clinical practice, and entirely different emergency response timelines.
So you might have aggressive contact tracing in one province and a completely hands-off approach in the neighboring province.
Exactly. The federal government often has to scramble, relying on indirect constitutional powers, like their authority over international trade or national security, just to try and coordinate a unified public health response.
So that is the geographical friction. But there is also friction within the government itself through the separation of powers.
The executive branch, the legislative branch, and the judicial branch.
Right. And I don't think we as healthcare professionals spend nearly enough time talking about the judiciary's role in public health.
We really don't.
We think about doctors and politicians, but we completely forget the judges.
The judiciary is incredibly powerful in health governance. They interpret the laws, they adjudicate disputes between the state and the individual, and they can strike down public health mandates entirely.
Wow.
Historically, public health law was heavily governed by the harm principle.
The classic John Stuart Mill concept, the idea that the government can only legitimately intervene in an individual's liberty to prevent harm to others?
Exactly. That is the fundamental legal justification for things like mandatory quarantine during an Ebola outbreak, or requiring vaccinations to attend public school.
Because your right to refuse a medical intervention is overridden by the state's duty to protect the community from the infectious harm you might cause.
Right. Your right to swing your fist ends where my nose begins.
That's a great way to put it.
Yes. But modern public health has shifted. We are increasingly dealing with the massive burden of non-communicable diseases.
Things like obesity, diabetes, injuries, and smoking-related illnesses.
Exactly. In these areas, governments are increasingly adopting a more paternalistic approach. They are intervening to protect individuals from harming themselves.
And how do they justify that?
The state argues that the collective societal and economic costs of these chronic illnesses justifies intervening in personal lifestyle choices.
And I imagine this shift from the harm principle to paternalism leads to massive, protracted legal battles.
It absolutely does.
The textbook brings up a really visceral example here, the tobacco industry.
Yes. The tobacco industry has famously and relentlessly used the judicial system to subvert, delay, and undermine public health legislation.
I mean, they must spend millions on lawyers.
They do. They use litigation not necessarily because they think they will win every case, but as a strategy to drain the financial resources of the state.
To tie up government lawyers for decades.
Exactly, and to create a chilling effect to scare off future regulation.
And on the flip side of that, look at the United States Supreme Court ruling on the Affordable Care Act, commonly known as Obamacare.
A perfect example.
The entire structure of national health insurance reform, affecting millions of lives, hung in the balance of 9 judges interpreting constitutional law regarding taxation and interstate commerce.
The courts are absolutely a major arena for health governance.
So if you are stepping into a leadership role in public health, you aren't just dealing with epidemiology, you are dealing with constitutional lawyers.
You really are.
Now let's talk about the actual levers of power. How does a government practically get its population or its corporations to do what it wants?
The text introduces a crucial framework here called Deber's Policy Instruments Continuum.
Okay, let's break that down.
It classifies the tools a government can use, ranging from the least coercive to the most coercive.
I want us to walk through all 5 of these steps. Let's use a hypothetical scenario. Let's say the government wants to reduce the rate of childhood obesity. How do they use step 1?
Step 1, the least coercive instrument, is exhortation. This is essentially the government asking nicely.
Asking nicely.
Yeah, it involves persuasion, education, and health messaging.
So this is running public service announcements on television, putting posters in schools saying, hey, eat an apple instead of a candy bar.
Yes. It is almost always the first tool a government uses because it is politically safe and relatively cheap. You are just providing information, assuming that if people know better, they will do better.
But we know from behavioral economics that simply telling someone to eat a salad doesn't always work if they live in a food desert.
Right.
So if exhortation fails, the government escalates to step 2. What is that?
Step 2 is taxation. Taxation is considered slightly coercive. It is about creating financial incentives or disincentives to shape population behavior without actually banning anything.
So in our obesity example, this would be implementing a sugar tax or a soda tax.
Exactly.
You apply a heavy excise tax on sugary beverages so they become significantly more expensive, hoping the price hike reduces consumption.
Exactly. You are altering the economic environment to nudge behavior, and taxation works both ways. The government might also provide tax exemptions for nonprofit community centers so they can afford to build gyms and run free exercise classes.
Okay, so we've asked nicely and we've tweaked the prices. What is step 3?
Step 3 is expenditure. This is considered moderately coercive, and it involves the government directly opening its wallet to buy the outcomes it wants.
Direct funding.
Yes.
So the government subsidizing the cost of fresh produce for lower-income families, or directly paying for a national rollout of free nutritional counseling in all primary care clinics.
Yes, exactly. It also includes the government directly contracting private NGOs to deliver services. The government is using its financial leverage to dictate how care is delivered.
Got it. And if the problem is still severe and throwing money at it isn't enough, we move into the heavy machinery. Step 4.
Step 4 is regulations. Now we are entering highly coercive territory.
Okay.
Regulations are formal rules of behavior backed directly by the sanctions and penal power of the state. If you break a regulation, you aren't just paying a bit more for a soda.
You can be fined, you can lose your business license, or you can go to jail.
Exactly.
In our obesity example, this would be the government legally banning the sale of trans fats in all restaurants, or mandating that all food manufacturers must put specific, highly visible warning labels on high-sugar products.
Or regulations dictating the nutritional standards of school lunches,
Yeah.
or banning vending machines in schools entirely. But what is fascinating about regulation is that the state often delegates this coercive power.
Wait, what do you mean by delegated regulatory power?
Well, think about medical licensing. The government allows the medical and nursing professions to essentially self-regulate.
Oh, right.
The state endorses a medical board made up of doctors to grant or revoke the licenses of other doctors. It is a hybrid form of governance.
It has the immense benefit of peer expertise, right? Doctors judging doctors.
Yes, but it carries a significant systemic risk known as regulatory capture.
Regulatory capture. That is when the regulatory body becomes dominated by the very industry it is supposed to be regulating.
Yeah.
So the medical board might subconsciously or consciously prioritize protecting the reputations and livelihoods of its fellow doctors over strictly protecting the public from malpractice.
Right. It's a constant tension in delegated regulation. Finally, we reach step 5, the ultimate coercive tool on Deborah's continuum. Public ownership.
This is maximum state control.
Yes, the state doesn't just ask, tax, fund, or regulate the service. The state owns the physical infrastructure and directly employs the staff.
The classic example is the National Health Service in the UK or the Veterans Health Administration in the US.
Exactly. The government determines exactly what services are available, where the hospitals are built, who gets hired, and how access is rationed.
Okay, so that is Deborah's continuum. Exhortation, taxation, expenditure, regulation, public ownership. That covers the government's toolkit.
It does.
But here's where things get really interesting. The text shifts from the government to the second major subsystem, the private sector.
Right.
And it introduces this concept of hybrid governance and the privatization of governance. I want to pause here because this challenges everything we usually think about who is in charge. What does the privatization of governance actually mean?
It means that the traditional clean line between what the sovereign government does and what private, for-profit, or non-profit corporations do has blurred almost beyond recognition.
Really?
Yeah. The private sector now wields coercive power that used to belong exclusively to the state.
I need a tangible example of this. How does a private company hold state-like power in healthcare?
Let's look closely at the United States healthcare system. The U.S. Congress passed legislation stating that for a hospital to receive Medicare or Medicaid funding, which is the financial lifeblood of almost any American hospital, that hospital must be formally accredited by the Joint Commission on Accreditation of Healthcare Organizations.
Commonly known as JCHO, or simply the Joint Commission.
Right.
But wait, the Joint Commission is a private nonprofit organization, right? It is not a government agency.
Correct. It is entirely private. Yet the federal government has explicitly delegated its ultimate regulatory authority to this private entity.
Wow.
If JCAO arrives, audits your hospital, and decides not to accredit you, you lose your federal funding. Without that funding, your hospital effectively closes its doors.
That is a private, unelected entity wielding the coercive, existential power of the state over a health system.
It is.
That is wild to think about. A private board of directors is essentially dictating federal compliance. The textbook also uses this deeply unsettling phrase, private government.
Yes. Political scientists and health scholars use that term to describe the immense, almost sovereign power of massive transnational corporations.
Oh, so.
Well, they can govern states not through laws, but through the threat of capital flight.
Explain capital flight in this context.
Imagine a developing nation wants to pass strict environmental regulations to improve air quality, or perhaps they want to heavily tax sugary foods to fight diabetes. A massive multinational corporation, say, a global food manufacturer, can simply approach the government and say, look, if you pass this public health law, it hurts our profit margins. So we will close our 3 factories here, fire 10,000 local workers, and move our operations to a neighboring country with weaker health regulations.
Oh, wow. So the corporation is essentially holding the nation's economy hostage to dictate its public health policy.
Exactly. The threat alone is often enough to force the government to back down. The corporation is acting as a private government, vetoing the laws of a sovereign state.
That's incredible.
And this private power also extends to physical spaces. Think about massive shopping malls, sprawling corporate campuses, or gated residential communities.
Right.
These are technically non-state spaces, yet hundreds of thousands of people spend their lives in them. And these spaces are governed by private security forces who dictate the rules of public order, smoking policies, and emergency responses within those boundaries.
The private sector is a colossal structural player in health governance.
It absolutely is.
Which brings us to the third subsystem, the counterbalance to the state and the corporation's civil society. Who exactly falls into this category?
Civil society is the incredibly diverse, messy, vibrant space between the individual citizen and the formal state.
Okay.
It encompasses non-governmental organizations or NGOs, philanthropic foundations, academic research institutions, labor unions, professional associations like the medical board we mentioned, and grassroots community advocacy groups.
And what is their role in steering the ship? I mean, if they don't have the legal authority of the government and they don't have the financial leverage of a multinational corporation, what power do they actually have?
They are the vital intermediaries.
Mm.
Their most critical function in governance is acting as a check and balance on government and corporate power.
Ah.
They advocate for marginalized groups, they demystify complex, jargon-heavy policies for the general public, and they demand accountability. The public health community itself, particularly academia and professional bodies, has historically been the vanguard of civil society, providing the hard, empirical evidence that advocacy groups use to push for systemic change.
The text details specific demand-side governance tools that civil society uses to keep the system honest. Can we break those down? Because this is how citizens actually fight back.
Certainly. These tools fall into three main categories. First is transparency and information.
Because if you can't see what the government or the corporation is doing, you can't hold them accountable.
Exactly. This includes utilizing freedom of information laws to expose internal government documents or corporate lobbying efforts.
It makes sense.
It involves civil society think tanks taking dense, 1,000-page government budgets and publishing short, accessible policy briefs that translate the numbers into language the public can understand. It's about pulling the data out of the shadows.
I love that. What's the second category?
Accountability mechanisms. These are formal grievance channels.
Like what?
Well, it could involve civil society lobbying the government to establish an independent ombudsman, a completely neutral office where citizens can safely report failures in health service delivery without fear of retaliation.
Okay.
It also heavily includes third-party monitoring.
Like an NGO conducting an independent audit.
Yes. For example, a government might claim its rural maternal health program is a massive success. An independent NGO will then go out, conduct their own patient satisfaction surveys, review the clinic data, and publish a report verifying or entirely debunking the government's claims.
That's a powerful tool. And the third demand-side tool?
Participation. This is about moving beyond just complaining from the outside and actually bringing the users of the health system directly into the formal decision-making process.
And the text gives a really fascinating, almost radical example of this from the UK, right? The foundation trusts?
Yes, the UK created a new legal entity for certain high-performing hospitals within their National Health Service, calling them public benefit corporations or NHS foundation trusts.
How does that work?
It is an innovative, albeit complex, model of citizen-centered governance. The trust isn't just run by a faceless board of central bureaucrats. It has a council of governors.
Okay.
And crucially, those governors are directly elected by three specific constituencies: the general public in the local area, the patients who use the hospital, and the clinical staff who work there.
Wait, really? So the nurses working the night shift and the chronic care patients who visit weekly actually vote for the people overseeing the hospital's executive team?
Exactly. They have a direct democratic say in appointing the chief executive, auditing the financial plans, and setting the strategic direction of the hospital.
That is amazing.
It is a structural attempt to deeply embed civil society directly into the formal governance machinery of the health system.
Okay, so we've built a robust understanding of our three pillars at the national level: government, the private sector, and civil society. We see how they push and pull against each other. But now we have to scale this up. What happens when these dynamics move to the global level? Because last time I checked, there is no world government.
Right.
There is no global parliament that can pass a law binding every nation.
And that absence of a global sovereign changes the physics of the entire system. We're moving into the realm of supranational health governance.
Okay.
To understand why this is so difficult, we first have to recognize the globalization of health determinants.
Right, because risk factors do not carry passports. They don't respect national borders.
Precisely. We easily understand this with infectious diseases. The rapid, terrifying spread of SARS or HIV or COVID-19 showed us how quickly a pathogen can travel the globe via commercial air travel.
Yeah.
But what the textbook heavily emphasizes is that we're also seeing the rapid, insidious globalization of chronic disease risk factors.
This is a huge point that often gets ignored. How do chronic disease risks globalize? I mean, a virus spreads through a cough, but how does obesity spread across borders?
It spreads through the global flows of goods, services, culture, and most importantly, marketing.
Marketing.
Yes, we are seeing a worldwide shift towards sedentary lifestyles driven by globalized economic development and rapid urbanization. But much more directly, we see massive transnational corporations aggressively marketing processed foods, foods extraordinarily high in salt, sugar, and unhealthy fats across the developing world.
Right.
We see the relentless transnational marketing of tobacco products shifting from highly regulated Western markets to less regulated markets in Asia and Africa.
So if you are a health minister in a low-income country, you aren't just fighting local dietary habits. You are fighting the marketing budget of a multinational food conglomerate located oceans away.
A budget that might be larger than your entire national health expenditure.
Wow.
Exactly. National governments simply do not have the jurisdictional capacity or the legal mandate to address these transglobal risk factors on their own. You cannot regulate a global food supply chain or a global digital marketing campaign solely from within one country's borders.
It requires a coordinated global response.
It absolutely does.
So how does the international community decide what to focus on globally? I mean, if there is no world government, who sets the agenda?
That is the million-dollar question.
The text outlines 5 distinct metaphors that define how global health is framed by policymakers, and therefore how it is governed and funded. I want us to walk through these carefully because they reveal the often hidden agendas behind international aid.
These metaphors are crucial for anyone working in global health to understand because the metaphor dictates the money.
Right. What's the first one?
The first metaphor frames global health as foreign policy.
Health as diplomacy.
Yes. Here, politicians use health aid instrumentally to foster trade agreements, build political alliances, or promote stability in a strategically important region.
It's very transactional.
Very. If this is the metaphor driving the funding, the money usually targets highly visible, acute infectious diseases where the donor country can fly its flag and show immediate goodwill to the recipient nation's leadership.
It's soft power. Hey, we will build you a hospital if you support us at the UN.
Precisely.
What's the second metaphor?
The second frames global health as security. The ultimate goal here is protecting the homeland of the wealthy donor nations from external threats.
So it's defensive.
Yes. The priorities under this frame are combative. Bioterrorism preparedness, pandemic surveillance for avian influenza, or containing multi-drug-resistant tuberculosis. The focus is exclusively on pathogens that could cross borders and destabilize Western economies.
So if a disease only kills poor people in the global south and doesn't threaten the global north, it doesn't get funded under the security metaphor.
Precisely. It is a highly defensive posture. The third metaphor is health as charity.
This is the classic one.
Yes, it is perhaps the most publicly recognized framing. It is about fighting absolute poverty. The focus here is on the diseases of extreme destitution, child malnutrition, malaria, maternal mortality.
It is driven by a moral imperative, often linked to religious or humanitarian organizations, to help the most vulnerable.
Exactly.
And the fourth metaphor shifts to a completely different vocabulary.
Yes, health as an investment. This is a strictly economic lens. The question is, how do we maximize the economic value and productivity of a population?
So under this frame, you aren't treating a patient because it's morally right. You are treating a worker so they can get back to the factory.
Correct. The focus here is overwhelmingly on diseases that hollow out the working-age population. This was a massive driver for HIV funding in the 2000s because the disease was killing off the most productive segment of the workforce, stalling macroeconomic growth across entire regions.
Okay, so we have foreign policy, security, charity, and investment. That brings us to the fifth metaphor, which the authors of the chapter argue is the only one we actually should be using.
Right. The fifth metaphor frames global health strictly as public health. The singular, uncompromised goal is to maximize health effects and reduce the worldwide burden of disease, regardless of political alliances, security threats to the West, or macroeconomic returns.
And if we actually use that fifth frame, the entire map of global health funding changes, doesn't it?
Drastically. If we strictly follow the public health burden of disease, we realize we have to massively pivot our global funding to tackle things like tobacco control, the obesity epidemic, and road traffic injuries.
Because mathematically, those are the actual massive burdens of disease-crushing health systems globally today.
Exactly. But they receive a fraction of the funding that infectious diseases get under the security or foreign policy metaphors.
But because we don't have a world government to enforce that rational fifth metaphor, we end up with a system described by scholars in the text as deterritorialization and open source anarchy.
Yes.
I absolutely love those terms. They sound like something out of a cyberpunk novel. What do they actually mean in practice?
Deterritorialization simply means that geographical borders, which have defined a sovereign state's power for centuries, are becoming increasingly irrelevant in global health.
Like we discussed with marketing.
Right. As we discussed, a national government cannot effectively regulate a global mass media campaign beamed in via satellites or govern a multinational financial system that dictates the price of vital medicines.
They are governing a physical territory, a patch of dirt. But the health risks exist in the cloud, in the global supply chains.
Exactly. The power of the state is territorially bound, but the determinants of health are deterritorialized. And because traditional state power is blunted at the global level, and there is no overarching global sovereign to take its place, we exist in an environment of open source anarchy.
Open source anarchy. It sounds like the Wild West of health policy.
It is a remarkably accurate description. It is a fluid, chaotic governance space that is equally accessible to state and non-state actors alike.
So anyone can jump in.
Yes. In this space, the traditional hierarchy is flattened.
Yeah.
A sovereign government might sit at the same negotiating table as a private philanthropic foundation, a multinational pharmaceutical CEO, and a global NGO.
Right.
And often, the powers of the corporate sector and massive civil society organizations are vastly magnified because they have the immense financial resources, the rapid flexibility, and the agility that slow-moving, bureaucratic nation-states completely lack.
Let's talk about those financial resources, because the power shift in global health funding over the last couple of decades is absolutely staggering. It fundamentally changes who is steering the ship.
The numbers tell an incredible story of power redistribution. Total development assistance for health, or DAH, quadrupled from about $5.6 billion in 1990 to nearly $22 billion in 2007.
That is a massive influx of money into global health.
It is. But it is not just the sheer volume of money. It is who is spending it and how they are choosing to spend it.
The textbook specifically highlights the Bill and Melinda Gates Foundation here, and I want us to pause on this because the implications are profound.
Yes. In 2007, the Gates Foundation alone spent an estimated $2 billion on global health initiatives.
$2 billion.
To put that staggering figure in perspective, that private foundation's expenditure rivaled the entire global budget of the World Health Organization, which was about $3.3 billion for the entire planet.
Wait, let that sink in for a second. One private family foundation, governed by a small, unelected board in Seattle, had a discretionary health budget rivaling the United Nations Specialized Health Agency, which is accountable to 194 member states.
Yes, it is a profound shift in global governance. And alongside private foundations, we have seen donor countries increasingly channel their money away from traditional UN agencies and instead route it through massive single disease global health initiatives, or GHIs.
Like what?
Entities like the Global Fund to Fight AIDS, Tuberculosis and Malaria, or JVI, the Vaccine Alliance.
Now, on the surface, to a layperson, more billions of dollars fighting horrible diseases sounds unambiguously great.
Of course it does.
But the textbook points out a massive, often ignored downside to this open source anarchy for the actual countries receiving the aid. What is the system impact of all these competing, well-funded global initiatives landing in a developing nation?
It creates devastatingly high transaction costs and system fragmentation for local health ministries. I want you to imagine again that you are the Minister of Health in a low-income nation. Your infrastructure is already stretched to the breaking point. You have shortage of doctors, and your clinics lack basic supplies.
Okay, I'm with you.
Suddenly, the Global Fund arrives with millions of dollars. Then PEPFAR, the U.S. AIDS Initiative, arrives with millions more. Then the Gates Foundation and bilateral aid teams from 5 different European countries all show up, offering you substantial funding.
Again, it sounds like a fantastic problem to have. I have a line of billionaires and governments wanting to fund my health system.
It sounds great until you realize that every single one of those donors has a different priority disease.
Ah,
Every single one demands a completely different vertical governance structure to manage their specific money. They all demand different monitoring and evaluation metrics. They all require separate, exhaustive, quarterly financial reporting.
oh, I see the trap. Your top public health officials, your best epidemiologists and managers, stop actually doing public health. They stop visiting clinics and designing local interventions because they are stuck in the capital city, spending 80% of their time writing exhaustive compliance reports for donors sitting in Geneva, Washington, and Seattle.
Exactly. The transaction costs of managing the aid overwhelm the system. And worse, it heavily distorts national health priorities.
What do you mean by distorts?
Well, you, as the health minister, might look at your local data and know with absolute certainty that your country's biggest, most pressing problem is clean drinking water, basic sanitation, and primary maternal care.
Right.
But the global funding available that year is only earmarked for a specific high-profile infectious disease.
So what do?
You follow the money.
Yeah.
Your entire fragile health system pivots to chase the global grant. You pull your best nurses out of primary care clinics to work in specialized, donor-funded vertical clinics.
That's heartbreaking.
You achieve the donor's narrow goal, but you leave the actual foundational needs of your population unmet. The massive influx of uncoordinated money without overarching governance can paradoxically weaken the holistic health system.
Which perfectly transitions us to the million-dollar question in Section 5. If open-source anarchy and fragmented aid is the problem, how do we define good governance? Is it just a philosophical concept, or can we actually measure something as abstract as governance?
It is abstract, but it is demonstrably measurable. The World Bank conducted a massive, sweeping empirical study called Governance Matters.
Okay.
They compiled over 300 different indicators of governance from over 150 countries across the globe. They didn't just look at health,
What else did they look at?
They looked at the macro level: political stability, government effectiveness, regulatory burden, the rule of law, and the strict control of corruption.
And what did the data actually show?
They found empirical, irrefutable evidence of a strong causal relationship between better governance and better developmental outcomes.
Really?
Specifically, they proved that good governance, a system with low corruption, high transparency, and effective rule of law, strongly correlated with higher per capita incomes, higher adult literacy rates, and crucially for our field, significantly lower infant mortality rates.
So good governance isn't just a nice political ideal to debate in a university seminar. It literally saves babies' lives. A transparent budget process in the capital city translates directly into a child surviving their first year of life in a rural village.
Exactly. Governance translates directly into biological outcomes.
This raises an important practical question. In this chaotic, multi-centric landscape we've described, with private hospitals, global NGOs, and multinational corporations all operating, who is supposed to be overseeing the whole thing? Who is the ultimate conductor of the orchestra?
This is where the WHO introduces the concept of stewardship.
Stewardship.
Yes. While governance is something everyone participates in, stewardship is the specific ultimate responsibility of the sovereign government.
Okay.
It is the government's duty to oversee, guide, and protect the entire health system, both public and private. It's about maintaining public trust, ensuring institutional legitimacy, and actively steering the collective effort of the state, the private sector, and civil society toward better health outcomes.
The text outlines 6 key stewardship functions that a government must perform. Let's run through them, because this is a great diagnostic checklist. If you are working in a health system that feels broken, it is likely failing at one of these 6 functions.
That's a great way to use it. Number 1 is policy guidance. This is setting the vision.
Right.
It is defining the national health goals, articulating the strategy, and clearly defining the respective roles of the public and private sectors.
Setting the compass. What's number 2?
Intelligence and oversight. A government cannot steer blind. This is about gathering robust epidemiological and economic data.
So asking, are our policies actually working? Are vulnerable populations protected from catastrophic financial ruin if they get sick?
Exactly. Number 3 is collaboration and coalition building.
Yes, because as we've established, the government cannot do it alone. They must build active working partnerships across civil society, academia, and the business sector to achieve public health goals.
Right. Number 4 is regulations and incentives.
What does that entail?
This is designing the rules of the game and ensuring they are fairly and consistently enforced to align the behavior of private actors with the public good.
Makes sense. Number 5 is systems design.
Ensuring the actual organizational structure of the health system fits the strategy. This is about avoiding the fragmentation we discussed earlier, ensuring that primary care, secondary care, and public health departments are structurally integrated.
And finally, number 6.
Accountability mechanisms. Establishing transparent, enforceable ways to hold all actors in the health system, public clinics, private hospitals, global NGOs, accountable for their performance and their use of funds.
Policy, intelligence, collaboration, regulation, design, and accountability. If the government isn't actively performing those 6 stewardship functions, the shit is drifting.
Precisely.
Now, we reach our final major concept, and it is a pivot from theory to practice. We've spent almost an hour deeply analyzing governance, but the chapter is titled Governance and Management. How is management fundamentally different from governance?
It is a vital operational distinction. Governance is about the what and the why. Governance determines the strategic direction, sets the overarching policies, allocates the power and the macro resources, and monitors the overall system performance. It is the realm of ultimate accountability and values.
So governance is the board of directors saying, based on our epidemiological data and our ethical values, we need to reduce maternal mortality in this region by 20% over the next 5 years, and here is a budget of $10 million to do it.
Exactly. Management, on the other hand, is the how. Management is the rigorous process of planning, organizing, leading, and controlling the specific resources, the staff, the equipment, the daily schedule, to actually achieve those goals on the ground.
So to use our metaphor,
Governance is the owners of the ship setting the destination. Management is the captain and the engineering crew charting the daily course, managing the fuel, and running the engines to get there.
but the textbook makes a crucial point. The context of how you manage changes drastically depending on the type of organization you are in. You can't manage a grassroots protest movement the same way you manage a corporate hospital.
Completely. The text draws a sharp contrast between managing a formally incorporated NGO and managing an informal community network.
How so?
Well, a formal NGO has a recognized legal status. It requires articles of incorporation, rigid bylaws, a formal, legally liable board of directors, and strict compliance with national tax laws. There is a clear hierarchical structure.
And what are the specific functions of a board of directors in that formal setting? Because many listeners might eventually sit on one of these boards.
A formal board has 4 main legally binding functions. 1, setting the strategic direction and protecting the mission.
Okay.
2, overseeing organizational effectiveness, which crucially involves the power to appoint, evaluate, and fire the CEO, as well as ensuring long-term financial sustainability.
Right.
3, maintaining external relationships, acting as ambassadors to major donors and the community. And 4, maintaining their own board effectiveness through proper recruitment, diversity, and rigorous self-evaluation.
But the text also mentions something fascinating called informal governance that boards desperately need to track, even in formal settings. What is that?
Informal governance is the unwritten culture of the organization. It's the traditions, the founding myths, the implicit values, the way things have always been done.
Right.
A board might pass a formal policy in a boardroom, but they must understand the informal culture on the hospital floor. Because, as the management saying goes, culture eats strategy for breakfast.
It really does.
If the formal directive clashes with the informal culture, the culture will resist, and the culture will usually win.
Let's contrast that formal, rigid board structure with managing an informal community network.
In a network of community groups, let's say 5 local neighborhood associations coming together to promote physical activity and build safe walking paths, there's often no legal incorporation. There is no legally binding board.
So how does it function?
Governance here is entirely based on voluntary participation, a deeply shared vision, and vital interpersonal trust.
So you can't just fire someone if they disagree with you.
Exactly. You have no coercive authority. You can't issue top-down directives. The management style in a network must be highly collaborative, diplomatic, and incremental. You manage by building consensus, not by issuing memos.
Which brings us to the actual day-to-day operational work of public health program management. The text makes a powerful statement. Public health management has epidemiology at its absolute core.
It does.
It is the integration of scientific knowledge with management execution, and it breaks down the program management cycle into 5 key questions. I want us to walk through these using a grounded example. Let's say a local health department wants to implement a needle exchange program to reduce HIV transmission.
Perfect example. Question 1 of the cycle is, where are we? This is the situational analysis.
What does that look like?
What is the current epidemiological problem? What is the local incidence rate of HIV among RV drug users? What interventions are known globally to be effective? What resources, funding, and political capital do we currently possess?
You have to know your exact starting coordinates before you move. Question 2, where do we want to be?
This is defining your desired specific outcome. We don't just say we want less HIV. We say we aim to reduce new HIV infections among the target population by 15% within 24 months. It must be a measurable health goal.
Question 3, and I think this is the one people skip all the time. Should we do something?
It is a critical, often uncomfortable step. Does the magnitude of this specific problem actually warrant the intervention and the expenditure of limited resources compared to other competing priorities in the community?
Right.
Is the political climate too hostile to survive the implementation? You had to rigorously justify the effort.
If the answer is yes, we move to question 4. What should we do?
This is the detailed operational planning.
Yeah.
Establishing the specific work plan. Where will the vans park? Who is staffing them? Assigning the exact budgets, defining individual responsibilities, and building the organizational structure to execute the needle exchange on a Tuesday night.
And the final question, number 5. How do we know we're getting there?
This is the controlling and evaluation phase. You must establish measurable milestones along the way. You track the number of clean needles distributed weekly. You track monthly clinic referrals.
Right.
You do not wait until the end of a 2-year program to see if it worked. You need constant feedback loops to tell you if the tasks are on track, so you can adjust the sails before you crash into the reef.
And that brings us perfectly full circle back to our ship.
Indeed it does. The engine, the crew, and the steering wheel all working in unison.
As we wrap up this deep dive, I want you to take a look at your own daily reality. Whether you are walking the halls of a massive teaching hospital, sitting in a rural primary care clinic, or analyzing data in a public health department. You are not just practicing medicine in a vacuum. You are not just delivering a siloed service. You are an active, vital node in a complex adaptive system.
Everything you do, every protocol you follow, is influenced by the steering mechanisms, the institutions, and the governance structures operating above and around you.
Which leads me to this final provocative thought for you to chew on as you go back to your shift. If open source anarchy is the true reality of global health today, with immense power dispersed away from governments and heavily concentrated among multinational corporations, private foundations, and civil society, how might tomorrow's public health leaders need to behave less like traditional doctors and much more like international diplomats and corporate strategists?
That is the exact complex challenge the next generation of leadership faces. And now, to ensure these frameworks truly stick, let's move to our rapid recall reinforcement. I will ask 5 single best answer questions based on what we have covered today. I want you to answer them in your head. Question 1. In Deborah's classification of government policy instruments, which is considered the most coercive tool available to the state? Take a second to think.
The answer is public ownership.
Question 2. Which term describes the modern global health governance space where traditional overarching state structures are absent and both state and powerful non-state actors operate freely? Take a brief pause.
The answer is open source anarchy.
Question 3. What term refers to the specific overarching steering function of a government responsible for the welfare of the population and the ethical oversight of the entire health system? Pause for a moment.
The answer is stewardship.
Question 4. According to the WHO's framework for strengthening health systems, which of the 6 building blocks is considered the pivotal central function that ensures the other 5 blocks work effectively together? Take a second.
The answer is leadership and governance.
Question 5. In the 5-step program management cycle, which phase specifically relies on the question, how do we know we are getting there, by establishing feedback loops and measurable milestones? Think about it.
The answer is controlling, or evaluation.
To consolidate this conceptual framework, we specifically advise you to revisit the sections on Deborah's policy instruments and supranational health governance in Chapter 6.8 of the Oxford textbook.
Here are the details of this episode.
Governance and management. Byline. Steering the system, how leadership, accountability, and organizational design shape public health outcomes.